Welcome to the Roselle and Friends talk show. Today we're looking at sickle cell disorder, which is an inherited blood disorder that affects people of all races. But here in the UK, sickle cell disorder is most commonly known among, or most commonly seen among those of African, Caribbean, Middle Eastern, Mediterranean and Asian origins. It's estimated that there are 15,000 adults and children with sickle cell disorder in Britain, and about 350 babies are born with the disorder here in the United Kingdom. Sickle cell anemia is a blood disorder that changes the shape of red blood cells so they become deformed and look like a sickle or a banana. Instead of being round and smooth to pass through blood vessels, because of their shape, sickle cells are difficult to move through the body. In fact, they often stick together to the walls of blood vessels, clogging up blood flow and cutting off oxygen to healthy tissues and organs, thus causing the sufferer to experience a crisis. Although the bone marrow tries to produce more red cells to deal with this situation, it's often difficult to manage. As a result, a person living with such a condition suffers from anemia, fatigue, very severe pain, and other serious health issues. To tell us more about sickle cell, you really have to hear from my guests. On my right is Dr. Russell Keenan, who is a consultant pediatric hematologist and lead for clinical and laboratory services for hemoglobinopathies for Liverpool, Merseyside, Cheshire and North Wales. Welcome, Dr. Keenan. That was a long introduction to your title.
It was.
Right. And on his right is Mr. John James from the Sickle Cell Society here in the London Borough of Brent. Welcome.
Thank you very much.
Thank you very much for coming. And last but not least, on my left is the lovely Sharifa Nandu. She's a mother of two and also a sickle cell anemia sufferer from Wolverhampton. I welcome you all to the programme. Sickle cell disorder, perhaps not so well known, and lots of people would be they're often confused or disturbed by many questions, even some myths surrounding sickle cell. So I think we should dispense with the myths. So I'm going to ask questions. Dr. Keenan, Mr. James, is it catching like measles or a cold?
As a patient organisation, we're very clear we prefer to use the term sickle cell disorder because it's not catching, it's not contagious.
Right.
It's a simple disorder of the blood.
Yes.
And many patients associate disease with things about not getting better or ill, and not able to go about their daily lives. Well, lots of people with sickle cell can go about their daily lives, but there'll be episodes of crisis which will affect that.
Right. Okay. So we're going to talk about language such as crisis in a moment. Dr. Keenan, is it leukemia? Is it cancer?
It's neither of those. Sickle cell, it's a severe disorder. It's a disorder that's inherited, so it's in our genes, and it comes from these areas, as you rightly said earlier, where primarily in sub-Saharan Africa, but right through into the Middle East and into Asia, in part where malaria was particularly, it continues to be particularly prevalent. The disorder, when children are born, they are completely normal, and there is absolutely nothing that you can tell them apart by looking at the children, and it's only by the time that they get to the latter stages of the first year after they're born, and then subsequently in the years after that they start to get some problems.
Okay.
And those problems is, although it's an abnormality of the blood and the red blood cells, and the main molecule in the red blood cells that carries oxygen around the body, the hemoglobin, the problem is the blood obviously goes everywhere.
Right.
So blood feeds every organ, every tissue in the body.
Yes.
So the problems that the patients present with are primarily where the blood is not actually doing its job. Not actually getting to that. So the problems it can be in any part of the body, but mainly focused on the bones, on the kidneys, and the lungs is a major area in children, but can also affect the brain in children as well.
Organs,
so for example, sickle cell is the commonest cause of stroke in the UK.
Right. Yes. Yes, yes. Even for children as well, isn't it?
In children, sorry,
Yes.
in children, not in adults. Obviously,
Yes.
in adults is different causes by the time we get older.
Wow.
And with the biggest problem in paediatric practice is actually getting crises or sickle problems in the lungs.
Right.
Because once you get problems in the lungs and the blood and the heart kind of work as one system. So once you get problems in the lungs, that affects the blood, which makes the lungs worse, which makes everything you can get into a vicious circle.
Right, and that's where the word crisis comes from.
Well, the crisis, I mean, most people with sickle cell, who live with sickle cell disease, most of the children who live with sickle cell disease, most days they feel fine.
Yes.
Or they feel pretty well. Not always necessarily 100%, but they're feeling well. And but they will have episodes where they get where they're not well, and the commonest of those episodes is pain in the bones, and that's because the blood supply is failing to areas of the bones, and that pain sometimes can be mild and moderate and can be managed with simple painkillers at home, and the children still going to school, but sometimes can then get out of control and can be very severe, requiring the strongest of painkillers and admissions into hospital.
Some say it's a curse on the sufferer. Is it a cultural myth?
It's a myth because, as Russell has described, it's a medical condition.
Yes.
But what we do know is that in some communities there is a lot of stigma. Related to sickle cell. So it's certainly a myth, but stigma persists, and some communities don't like to talk about it, or they don't want people to know that they have it, or their children live with sickle cell.
Yes.
So that can be a really serious
and
issue.
A barrier to treatment.
Indeed.
Yes.
Indeed.
Yes.
And I think what's really important is that we raise the profile of it and allow those people who feel a little anxious about sharing the fact that they have sickle cell to talk to other parents, mothers, other adults, because there is nothing to be ashamed of.
If you go back 20, 30 years, or even whenever I was in medical school, doctors didn't tell their patients they'd got cancer.
Right.
Because you didn't do that. We just didn't talk about that. But it's only whenever you do start talking about it, you can start breaking things down.
Yes.
And I really like what you said in one of the words there, and you said about the people and the children living with sickle cell disease. I much prefer that language and vocabulary, because I think the language and vocabulary is important.
It is important. It is. Absolutely.
To saying sufferers of sickle cell disease, because people use the word sufferers in many conditions. It's not just sickle.
Yes.
But for me, I think it's the wrong sort of psychology, because what it is doing is it's identifying the sickle cell as actually the most important. You're centrally, you've got sickle cell disease before you're a person. Actually, you're not. You're a person
living with it.
With sickle cell disease.
Totally agree.
And that's how I think I would like to change the vocabulary.
Thank you very much. Well, we've got Sharifa, and you are someone who's living with the sickle cell disorder. I wanted us to talk in some detail about, your own experience, that journey you've had so far. And you mentioned before that the troubles began in your secondary school, although you were born with it. Tell us something about it.
I was born with sickle cell, and it never really bothered me in my childhood. The first incident I had, I was having problems with my legs. I was having a lot of pain. I went into the hospital. I was admitted, and the doctors wasn't sure if it was a sickle cell crisis, but they put it down to that because they had nothing else to put it down to.
Right.
And then it didn't start bothering me until my first pregnancy properly. And I think about 5 months into the pregnancy, I was having trouble breathing, and I was having a lot of pain, and I was very uncomfortable, and I was admitted then again, and it took them about 5 weeks to find out that I had a clot in my heart, which was caused by the sickle cell.
Was that a crisis?
It was a type of crisis,
right.
but it's not one of the commonest crises that people would talk about.
Right.
But sickle cell disease is well recognised as being a cause of blood clots. It's a risk factor for getting blood clots.
Okay.
So it took a while for them to identify it. And then obviously, because I was so heavily pregnant, they couldn't treat it until after. So when they found out I had it, they were giving me transfusions every 2 weeks during the rest of my pregnancy. And then after my pregnancy as well, I was having a lot of transfusions and I was crisising quite a bit. I think it was the body reacting with the pregnancy, with the sickle cell as well. So, yeah, it was quite hard then.
Right, but you went on to have another
But
child.
yeah, I did.
So you see, it bears out what you've said about living with the
I
crisis.
wanted another child.
Yes.
And I went for it, and it was different with the second pregnancy because the actual pregnancy itself was okay. It was after the pregnancy that the sickle kicked in more than it ever had, and my kidneys started to fail, and even then again, they wasn't sure what was going on. They just were putting everything, it's your sickle cell, not taking in fact that my body's doubled in size because of fluid intake and stuff like that. They were just trying to put it all on the sickle cell, but it wasn't. It was my kidneys failing.
And were you in a lot of pain?
I was in a lot of pain, a lot of discomfort. I was on high levels of morphine.
Right.
I was on, it's called a PCA machine, a machine which is connected to myself that I press to self-medicate, if you want to put it that way.
Right, yes.
So anytime I was feeling the pain, I would press the button and it would administrate morphine to my body.
Right.
I mean, being on a high level of pain relief is horrible in itself, let alone anything else.
But things deteriorated greatly from there on.
Yeah, they did. My body was expanding a lot and they weren't sure what was going on. Once I finally decided that I did have kidney failure, I had to start dialysis, and I'm on it 15 hours a week.
Right, even now?
Yeah, even now, yeah.
Right.
So hopefully I'll be able to go on the transplant list eventually, but then they said, again, with sickle cell, I might be waiting up to a good 10, 20 years for that transplant. Just
How does
because
that affect
of the
you?
fact I've got sickle cell.
How does it affect normal life for you?
Normal life, I think the main things is the aching of the joints, the feeling tired, feeling drained. With me, I have a lot of problems with walking and in my hips, and it is a lot of joint pain.
Yes.
And it's not nice being on. All they can offer you is high pain medication, and you don't want to be on that 24/7. You can't do anything on it. You can't. I can't look after my children if I'm on high rates of morphine, and I can't get up and cook and clean for them.
And jobs, employment, that's a no-no.
There's no point. No one would want to employ me because I'd probably have so much time off. But then, as the person I am, I've never not worked. So, you know, like now I'm trying to get back into voluntary work and stuff like that because it's easier for me to be able to have that flexible working environment more than having a full-time job. And
It's very important that our raising awareness is for employers as well.
Absolutely, yes.
Because we know from some people who live with sickle cell that they're reluctant to share when they get a job that they've got sickle cell for fear.
You're just afraid that you're going to be, you know, not
so we have a responsibility to raise employers' awareness. And I'll just very quickly give you an example of a case that we dealt with, which we helped. A young man got a job with one of the big supermarkets. But what they did was that he had to go to the big fridge. He had to go to the cold section to take things from the cold section.
Of course, it affected him.
Of course, that means that he's more likely to get a crisis. So we helped him with that. But again, employers need to know if you've got somebody with sickle cell, you're not going to put them in the cold section. And I think the final point, because we do still, as recently as the end of last year from some surveys we did, there are still some hospitals, some clinicians who view people who need morphine and serious painkillers as drug.
Related to drug taking.
That is unhelpful. So those are the 2 points I made. It's really important. Congratulations with what you're doing.
Absolutely,
and so forth. But I just wanted to make those 2 points, Roselle.
I agree with both of those points absolutely wholeheartedly. In terms of I think there is some doctors and nurses that still have negative perceptions in terms of people. But I hope that that's in the minority whenever it probably was in the majority, maybe even 10 years ago.
Yes,
Yeah.
yes.
But also in terms of employment, I don't want people to get the impression that most people with sickle cell disease are not working. 'Cause
Yeah,
actually
that's right.
The
A lot
vast
of them
majority of people
Are
with-
working.
Yeah.
Well, my children with sickle cell disease, if they're not in school, I want to know why.
Yeah.
Because
Yes.
actually they should be in school, they should
Definitely.
be thriving, should be academically achieving,
Definitely.
and they should be aiming, especially with the modern therapies that hopefully we'll come on to later,
Yes.
aiming to have a fulfilling
Yeah.
life as
Childhood,
close to
yeah.
normal as possible,
Yes.
living with their disease. And it may well be that in your individuals, I think it's actually your 15 hours of dialysis a week
Yeah,
is
yeah,
probably
definitely.
more of a
More.
limitation.
Yeah, it is.
That's
than
it.
your
Than your ability to
sickle cell
work,
disease.
yes.
And actually,
Because before I was on dialysis, I was working 39
Yeah.
hours a week. And
Right.
Yeah, I was running
with the
around
sickle
with
cell,
young people,
yes.
and on a good day I was fine. On
Yeah.
a good day I was fine. It was a bad day that you might not be able to go and play tennis or whatever, but
Yes.
try and get on with it as much as you possibly can.
Right,
Yeah.
right. Well, I mean, thank you very much for telling us about your experience. The Sickle Cell Society here in London Borough of Brent was set up some 40 years ago in 1979.
approaching 40 years,
Yeah. Formed by a group of patients,
Yes.
parents, health professionals, all concerned about the lack of understanding and, inadequacy of treatment for sufferers. I mean, there are high quality standards, and Dr. Kinnan will bear me out here, but I was more concerned about awareness, driving down awareness.
The society's role is to raise awareness. And I mentioned its employers, it's people who live with sickle cell and their families and their carers as well.
Absolutely.
So it's within that community and schools. And it's a really challenging task, but I can say hand on heart that the society has made progress over those many years, but we still have an enormous long way to go.
Right.
So let's take schools. We go into schools, we use Black History Month,
Yes.
we use World Sickle Day. Not many
Yes.
people even know there's a World
That's
Sickle
right. That's right.
by the World
Yes.
Health Organization.
Yeah.
So we use key events as well as regular raising awareness. But it's very clear to us that we still need to do a lot more. So schools in areas of high prevalence of sickle cell, be
Right.
that the Northwest, the Midlands, London, schools can pick and choose. I attended a school recently to talk to some pupils, and there were 6 children with sickle cell there.
6, right.
4 of them didn't know that the others
Had it.
had sickle
That's
cell.
amazing.
That's
4 of them
amazing,
didn't
isn't
know,
it?
And schools pick and choose whether they
Yeah.
want to
Right.
get involved. So I think that the point that I'm making is we do a lot to raise awareness. We have a BBC Radio 4 repeal coming up in May.
Right.
That, particularly for Radio 4 listeners, that will help.
For the society.
For the
Right,
society
okay,
and
good.
the cause of sickle cell.
So I would agree that it's time to level the playing field for sickle cell. Right. So what can people do to help the society? I mean, what about funding? How is that funded?
The vast proportion of our funding comes from the good people out there who give donations to
Right.
us. So we have a high proportion of people who just give
Right.
to support the cause of sickle cell. We then have a smaller proportion where we get grants, and those grants might come from the big lottery.
Right.
They may come from the NHS through public health because of screening and raising the awareness when people are pregnant or
Right.
planning families. So we get grants as well, and that's where we get most of our funding from. But to answer the first bit of your question, many groups have events for us.
That's
So
wonderful.
whether they're
Yes.
cookouts, whether
Yes.
they're barbecues, whether
Great.
they're dinner and dances, and those things raise funds, but they also raise awareness.
We want people out there who would be passionate, like our young lady here, and like yourself and Dr. Keenan, to raise the flag.
Yeah.
To run out there and get people aware of the fact that there is need here.
The management of patients with sickle cell disease, or people living with sickle cell disease, has changed just in the last few years, really.
Right.
It used to be going back, certainly going back 10 years ago, that essentially the management was nothing. and it was essentially firefighting. So basically, people were just out there on their own, maybe with some painkillers and things, and with support, but living and struggling with sickle. And then when a crisis happens, they come in, and we basically try to dampen down the fire and then get them out again. And then in between, we did very little. And across the country, in the development countries, our focus is much more now on prevention, on picking up early signs of any damage, and actually preventing the crises from occurring. But there's two things we need to prevent, and I think your experience, Alice, in that you had very little way of acute problems in your early childhood years. That's not that unusual. Many children do. But then by the time that you got to a teenager, an older teenager, you were already running into some serious problems with your kidney. We're checking for a number of things. We're checking for early signs of kidney damage. We once a year we check for signs of any changes in the blood vessels flow in the brain that can be a risk for stroke. So we're checking for oxygen levels in the blood, checking for lung function and things as well. So we're checking for lots of things.
When you say that as well, that is so good, because I know every time I went to the GP when I was younger, he always said, "You've got protein in your urine, you've got protein in your urine." I would say, "Okay, it's just your kidneys." But they never ever said anything else apart from that. You got protein in your urine. But obviously that was a sign of my kidneys.
The protein in your urine is the first sign of sickle kidney damage. And we know that we can prevent that. And we've got, but we probably didn't know
at the time.
But we now know that not only can we prevent that I've had patients referred to me who've got very high levels of protein in the urine, and then we treat them. And the protein levels drop. So to a level, that means if we jump in, even if it's not right at the beginning, jump in reasonably early, we can probably reverse that sickle damage. The kidneys can heal and recover. There obviously is a point that you would get to that the kidneys are so badly damaged that there isn't recovery. But so it's all about treating and preventing early.
Absolutely.
Now, the treatments that we've got, and I'll just run through some of them, in terms of treating the underlying disease. One is a bone marrow transplantation. A bone marrow transplantation is probably the worst treatment that we've got in modern medicine in terms of its risks and its intensity of therapy. Even if we wanted to do it with everybody with sickle cell disease, in terms of having an available donor, we might be getting somewhere between 1 in 4 and 1 in 10 patients that we could ever give it to. And it is still such a risky thing to do that it's only going to be, in my view, suitable for a very small minority of patients.
That's right, yes.
For most people, can't put that one out.
Can you only have donations from your siblings, or can it be from non-siblings?
The best donor is a brother and sister who happens to be a full match. The brother and sister has to be a full brother and sister, and each brother and sister only has a 1 in 4 chance of being a full match. So you can see that how many times you can have a transplant from an unrelated donor on the panels, but that is an order of magnitude more dangerous thing to do. There is some issues because that most of the bone marrow registries are in rich countries and with a predominance of white Northern European people.
You can
transplant across racial boundaries, it just increases the risks. So there is issues there, and I think the bone marrow transplant at the moment has an important role for a very small number of patients.
Small amount, yes.
The other two ways of treatment, one is regular blood transfusion. So regular blood transfusion, the sickle blood is at a high level. If you give normal blood, you can basically push that down and get and you get it to roughly 1/3 of the blood being sickle and 2/3 of the blood being a normal transfused blood. That is doable, and there's about 1/4 of the patients around the country that are on a transfusion program like that. It is quite an endurance test because you're in hospital for about 1 day every 4 weeks or so. And it's not without its problems, one of which is when we give blood that you're building up the iron in the body, and that is sometimes easy to get out, but not always that easy to get out, and can cause problems and can shorten life in itself. So it kind of swaps one problem for another, and it doesn't stop all sickle problems, but it can certainly reduce them, and it is effective. Hydroxyurea is a medicine, so you can take it either as a tablet once a day or in a liquid for the smaller children. It's a medicine that we know a lot about. We've used it clinically for about 50 years in other conditions, and it has been used in sickle cell disease for about 25 years.
Right, so you've got a couple of decades under your
with
belt.
increasing evidence. In the early days, we worked out that it prevented the acute problem, so it reduced crises, reduced the need of coming to hospital, reduced needed blood transfusions.
Wow.
Obviously,
Yes.
the long-term, proving that it prevented long-term problems and proving that it was suitable for children and things like that was obviously going to take longer.
It's
But
time.
and there's still, the information is still developing, but we've certainly got overwhelming evidence now of the
That's
benefits
marvellous.
of hydroxyurea.
That is really marvellous. So, I mean, really what we're hoping is that this programme has stimulated some discussion, or will stimulate discussion amongst patients, families and professionals. Certainly, we want people to become so aware that they need to ask and will ask questions. I hope this programme has provided you with a better understanding of the disorder, because really it's only by being aware, working together, that sufferers can get special care, welfare schemes, as well as treatment that is really long overdue. And I think the future is positive and it looks bright, you know, having listened to Dr. Keenan and, you know, the kind of treatments that are now out there. So what I need to now say is thank you all very, very much for coming.
Thank you.
It's been an absolute eye-opener listening to all of you, and I really hope that you, the viewers, will feel now more positive and braver to talk about some of the problems you're experiencing with sickle cell. And for, you know, by all means, you must contact the society. Dr. Keenan he's at Alderhay Hospital. You know, there is information out there. There is treatment, so the future looks good. And with that, thank you all very much for coming to our show. Thank you all.
Thank you, Roselle.